Or
We are live.
yeah, good evening, everyone. So this is
No, wait. Sorry. Now we are live. Yeah.
yeah. Hi, good evening, everyone. So after a couple of weeks of break, we are starting again now. This is pertaining to a specific therapy called sclerotherapy for endometriosis, especially only the ovarian endometriosis. So there is a lot of talk about the sclerotherapy and how it can be an option. So does it really deserve to be a choice in treatment of ovarian endometriosis? Today we will, I think, listen from Dr. Jay, because he has done quite a few number of cases and has followed up the cases also. So yeah, over to you. After that, I'll ask the questions.
Yeah. So guys, I want to make one thing very clear. Initially, I was also not a very big believer of sclerotherapy. Okay. Because I was the one who was ending up to handle so many complications of sclerotherapy, which were being practiced across the city. So what typically used to happen at that point in time, I'm talking of around 18, 19, 20 months back. What used to be typically happen at that point in time is that people would attempt sclerotherapy, okay, and thinking and telling to the patient that sclerotherapy is going to be curative for endometriotic cyst. Understanding? When you go through the operative notes at that point in time, and a lot of people even practice the same thing today, which is why they end up cursing sclerotherapy and talking that sclerotherapy is don't giving them results. Understanding? So what they do in that situation is that they do a transvaginal needle, like how we do OM pickup, coming, drop, same needle. That needle they are putting inside the endometriotic cyst from the vagina. After they put that needle from in the vagina, they will empty out that endometriotic cyst. Once that endometriotic cyst is emptied out, they will use a preparation, 95%, 99%, 100% alcohol. All this is commercially available. Nobody has to sit in your OPD and manufacture all these things for you. Commercially available, 700 rupees. Not very expensive also. Understanding? These solutions are pre-available. Some of them would mix some small media, IVF media with it. Some of them would mix, little dilution with normal saline and whatever. And they will push it through the same pickup needle inside that ovarian cyst, re-aspirate it, re-push it inside that ovarian cyst and keep it inside for maybe 7 minutes. Somebody would keep for 10 minutes because there is no guidelines to this. Understanding? There is no guidelines. Nowhere it is written, no, you keep for 11 minutes, 45 seconds. All that is not written anywhere. Okay, so people would randomly, oh no, my experience of doing huge number of 2 cases has taught me that I should keep it for 10 minutes. No, that was being practiced at that point in time, which is why what used to happen is that many a times this pickup needle would actually go through the endometriotic cyst and cause that endometriotic cyst to rupture inside only. Understanding? Which would cause a lot of endometriotic chocolate material to get discharged in the pelvis, forget coming out through that needle. Okay, that is one thing. Second, very big problem was lot of people were attempting to do sclerotherapy. In Bombay, traveling endoscopic surgeons is charging so much less. You call them, they will do full endometriosis surgery, whatever they know, for 15-20,000 rupees. And to save that 15-20,000 rupees, people used to attempt ethanol sclerotherapy in multiloculated endometriotic cyst also. Okay. But remember one thing, that is one of the biggest contraindications to use ethanol. Okay. No use of ethanol sclerotherapy in multiloculated ovarian cyst. For endometriosis, only to be used in unilocular endometriosis, even if it is bilateral, but it has to be unilocular. Okay, it has to be, even if the endometriosis is bilateral ovaries, it has to be a singular endometriotic cyst. One more thing I want to tell you. Once upon a time, people were following criteria that if cyst is less than 5 centimeters, cyst is less than 3 centimeters, cyst is less than 4 centimeters. Again, no clear guidelines to this are existent. When we started doing sclerotherapy approximately 15-17 months back, okay, at that point in time, we never kept a size criteria. Okay, we never kept a size criteria. We only kept AMH as criteria. Okay, if AMH is less than 1.5, we would also counsel a patient with unilocular cyst to undergo ethanol sclerotherapy. Cyst is 7 centimeter, no problem. 3 centimeter, no problem. 2 centimeter, no problem. We will counsel if it is AMH less than 1.5. Understanding? Second, very much more important thing. In this situation, a transvaginal ultrasound of the endometriosis mapping is a game changer. Okay. This transvaginal ultrasound will accurately predict. I will draw something and show it to you. See this. This is a common picture which we see. Just see this. Madam, is the screen this thing visible?
Yeah.
See this. I was just drawing sclerotherapy for somebody actually. So now I will just show you how it works. See this. All right. Now, if this is the ovary, this is the uterus actually, which I am drawing, and you have fallopian tubes here. You have fallopian tubes here. All right. And these are your two ovaries. All right. So now what you are going to have is that you are going to have an endometriotic cyst, something like this. Correct? No? This will be your endometriotic cyst. Okay. You will have some antral follicle count, which is arranged peripherally here like this. So now what people would think in this situation, oh, nothing, just take your transvaginal needle and puncture this whole thing through the vagina, aspirate it out so that cyst will become empty and your job is done. But you know, people actually forget a very important aspect in this. This endometriotic cyst can also have walling off of the bowel. A bowel has come, most cases it is going to be rectum. It is called walling off. One wall is formed by the uterus of this endometriotic cyst. Only this much wall is formed by the ovary. Rest of the wall is actually a walling off which has occurred at a particular point by the bowel. So what typically biggest mistake used to happen is in our training of doing ovum pickup, we actually like to go through the center of the cyst. When you do ethanol sclerotherapy and when you want to get it done very, very effectively for your patient, please remember ethanol sclerotherapy needle should enter through the thickest part of this cyst. Okay, that is the point where the probability of rupture is the most minimum. That is the point where adhesions are not going to give way. That is the point where your needle will be stable. And I think this was the mistake which 99% of the people were making at that point in time. Understanding? Now, second very, very important thing which you should remember in this situation. So I'll just tell you what we follow as a protocol. Once everything is aspirated out, okay, once this entire endometriotic cyst has been, let's say, aspirated out completely by us, what we will do is that this empty thing which you see now, inside that, we will fill it up first with normal saline. Understanding? Then just re-aspirate it out. Okay, then we will put alcohol plus steroid plus tramadol, one vial. Now, don't ask me why I am putting tramadol one vial. I also don't have any logic. I also don't have any answer. But when first time we asked our anesthetist to prepare, he prepared it with alcohol plus steroid plus tramadol, thinking that it must be for pain relief and not for this thing. And ever since that time, we are using tramadol also inside this. I don't know if it is alcohol which is going and acting or it is tramadol which is going and acting. I don't know. Understanding? We keep it exposed inside the cyst for 15 minutes. Okay, for this 15 minutes, you are supposed to only do time pass. You are not supposed to do anything else. Okay. Do we do it transvaginally? Do we do a transvaginal needle? So the answer is you always do laparoscopy guided transvaginal needle. The reason is if there are adhesions which are present here on the fundus, fallopian tube, all these adhesions, pararectal space, everything to be freed first. Go to the vagina, clean the vagina with betadine. We obviously give antibiotics. We have very recently, last 8 months, we have started to do a high vaginal swab also for all these girls. So that if everything is negative, we give Metrogel and then we do all these things to avoid this. But after your sclerotherapy is done, that means after you aspirate this entire alcohol thing, okay, after you have aspirated and your needle has gone out, no, your ovary will be appearing something like this. This is your ovary, okay, and then there will be a bright sort of white band which will be appearing where both the walls have collapsed over each other. Understanding? In this, you are supposed to keep your negative suction pressure at 200. Do not follow IVF protocol. Keep it at 200 millimeters of this thing. No further exposure. But after this is finished, go put your laparoscope, do completion surgery, do a peritonectomy, because peritonectomy is very, very important. Do adhesiolysis. 99% of the people don't do it because they think that they should not do it. Minimally invasive and this and that and all that. They keep on speaking. Go do peritonectomy, go do adhesiolysis, separate this ovary. Automatically, when you go and separate this ovary, what will happen is, see, if I just draw endometriosis in adhesions, what will happen is some microvasculature which is going from ovarian cortex onto the bowel, some is coming from the bowel onto the ovarian cortex. Okay, this microvasculature which is going from the ovarian cortex onto the bowel. Now we have also done some studies, not studies, I think these are just our surgical itch, which we have done, where we have put ICG inside this in order to see how is the vascularity. And remember, when you do adhesiolysis, the ovary regains back its original vascular feedback, as a result of which the follicles do not suffer from hypoxia. And if you do this very nicely, what is going to happen is that post adhesiolysis with sclerotherapy, your ovary will be, one part will be very hard. It will be very hard because it will be folded and joined on one another. Okay, and the rest of the ovary will be very supple. And after doing this entire sclerotherapy, we give 50 days of oral contraceptive pills irrespective of what they want. 50 days of OCP. Okay, because no matter how good sclerotherapy you do, there could be some endometrial gland which you have missed out, and some endometrial gland where alcohol has not gone and caused ablation. Okay, so one more thing you should remember in this situation. Many times, if you don't follow this protocol, alcohol can leak in the peritoneal cavity. Anybody who wants to experiment, and if you hate somebody, like for example, Shilpa madam hates me from the bottom of his heart. Okay, then you can open my eye and take this 100% alcohol and put 1 drop of alcohol inside this eye. What will happen is, any mucosal contact to this alcohol, the alcohol injury, the burn which that alcohol causes, is a very severe burn. Understanding? Same thing can happen to the intestinal serosa also. Nothing happens to the appendices epiploicy, it is fat. But same thing can happen to the intestinal serosa also. Remember, when you have a unilocular endometriotic cyst, there is a 50% chance that the bowel would be adherent. When you have a bilateral endometriosis cyst, there is a 95% chance that the bowel will be adherent. As a result of this, and we have seen this clinically in our surgeries, I am sure Dr. Shilpa will agree to this after seeing so many endometriosis surgeries which we do. So what typically happens in this situation is that you should ensure that bowel adhesiolysis is done as soon as your sclerotherapy is finished. Understanding that alcohol will not drip out, but you should ensure, okay, you should ensure that bowel adhesiolysis is done. It will prevent you all forms of complications. Okay, see the type of complications which I used to see at that point in time. The most commonest complication, okay, the most commonest complication was abscess formation. And that abscess formation used to occur in the ovary because of migration of transvaginal bacteria going inside that ovarian region. And that causes an abscess formation, which is why I am telling, keep that pressure at 200. Okay, that will suck out almost everything, even if there is a blood clot. No, don't always think that chocolate colored thing means that everything will be liquid only. Sometimes there is a liquid component, sometimes there is that little semi-solid hemorrhagic component also. That semi-solid hemorrhagic component should also get lysed. So when you see that semi-solid hemorrhagic component, go to your IVF laboratory, get Hylase. Everybody has IVF. Everybody has Hylase inside. Put 5 drops of Hylase, 20 ml normal saline, and push it inside. It will lyse that entire clot and you will be able to aspirate it out. Don't make that mistake, because I made that mistakes in the very beginning when I did all these things. Okay. Now when we do sclerotherapy, the whole thing is stuck to each other, that ovarian cortex. Obviously, endometriotic cyst is going to grow in the cortex. So don't think that when you do sclerotherapy, there is no damage to the AMH. Wrong. There is a reduction in AMH. when you do sclerotherapy also. 100%. Okay. There is reduction in AMH when you do sclerotherapy. 100%. No doubt in that. Important. Many people is going to ask this to me personally. You are supposedly very good laparoscopic surgeon. Why you don't do sclerotherapy laparoscopically? Because in order to do sclerotherapy laparoscopically, I will require endo ultrasound, which is not practical. I need to monitor how that cyst is collapsing on ultrasound, which is best done on transvaginal ultrasound for these cysts, which is why we do it transvaginal sclerotherapy, but rest of the surgery is done laparoscopically. What people used to do before was they used to do only transvaginal sclerotherapy incompletely. And then they used to think that, oh, sclerotherapy is bakwas, it is not working at all. Okay. But if you do it correctly, if you follow these guidelines, your complication rate with sclerotherapy is next to zero. We don't even put a drain. We hardly give pelvic wash. You will hardly see me giving pelvic wash in my surgeries. We don't even give pelvic wash in this because we have never punctured the other side of the cortex. So what has happened is everything what we have done is through that intracortical layer only. Okay. It of course requires some skill set of being a good IVF specialist where you are trained in doing transvaginal pickups. All right. Which is going to be much more beneficial, obviously. And remember one more thing. This surgery is incomplete till you do adisholysis and peritonectomy. That ovary where there is an endometriotic cyst from the ovarian fossa, peritoneum has to come out. There is no question. There is no doubt. You can't put sclerotherapy in the peritoneum. You can't put sclerotherapy in the ureter. Ureter will blast. Understanding all these things you can't do. Sclerotherapy is one small part of a very big surgery. Sclerotherapy is not only sclerotherapy as a surgery. Understanding? It has to be treated as a small part of fertility conserving surgery. So now people will ask, you just right now mentioned, I think Shilpa madam will only ask this question, that you right now mentioned that AMH goes down with sclerotherapy. So then why should we give any importance to doing sclerotherapy? You are so good at doing ovarian cystectomy. Do ovarian cystectomy and get out. What is the need of doing a sclerotherapy in the first place? AMH goes down for sure. Okay. But when you do ovarian cystectomy in endometriosis, actually, we all know from the bottom of our heart that along with that cyst wall which is coming off, some cortex also comes off. Okay. So we are doing more of partial oophorectomy sort of a thing when we do a good endometriotic cystectomy. Simultaneously, even if you are God, okay, you and I know some people, especially where Shilpa madam is practicing, they don't like to use any electrocoagulation when adisholysis of the ovary is happening. They allow it to bleed. 1 liter bleeding is okay, but no electrocoagulation. Understanding what typically happens is, even if you don't want to use electrocoagulation, you will use some electrocoagulation. Understanding, and in that some electrocoagulation, that cortex does get affected. We all know this for sure. Okay, this may help you treating patients who have a low AMH. As I mentioned, my criteria is AMH. My criteria is not the size of the cyst. If the patient has low AMH, wanting fertility, try to do sclerotherapy effectively. It will reduce that AMH. That 1.5 will probably become 1.3. Okay, but that 1.5 will not become 0.5. And you will give this lady a good shot of then getting stimulated with his own eggs, getting embryos with his own eggs, so that she can form and have a successful pregnancy with a self cycle. Okay, this is the advantage. This is why we started doing it. We have now done 100 cases. I have had, out of these 100 cases, I have had recurrence, repeat cyst formation in 16 patients. Okay, these were initially my old patients in whom I was also not very good. Okay, but you will be surprised, last 48 patients, we've had no recurrence. Okay, zero recurrence, and almost out of these last 48, around 31 or 32 has had a 3-monthly follow-up. We've also had patients who have undergone stimulation after this with us, and they've had pregnancies with this, with self cycle. Okay. So this was my experience. This was my practical journey into sclerotherapy. Shilpa madam, I will be happy to answer 2 or 3 of your questions.
Yeah. So we have the aspiration of the cyst, we have cystectomy, and we have sclerotherapy. Among these three, everything has its own role in fertility enhancement.
No. Aspiration has no role. Because in aspiration, basically, you are just breaking that cyst. Okay. aspirating everything, leaving the endometriotic glands inside.
Yeah.
Okay, and then you are wanting Lupride or Dynogest or whomsoever is your brother to go inside and act on that endometriotic glands and do the job for you. So that the drainage has no role. Understanding. The debate will always be continued between sclerotherapy when done effectively versus cystectomy.
Okay, yeah, I got that point. And so we have patients with fertility issues who are symptomatic with severe pain, and some are not symptomatic, some are asymptomatic. So according to you in sclerotherapy, I mean, after you doing the adhesiolysis laparoscopically and doing the sclerotherapy, have you seen any advantage with regard to the symptom relief compared to your cystectomy? Is it better or is it not very optimal?
Symptom relief will only happen with adhesiolysis. There is no question of symptom relief in doing cystectomy or sclerotherapy. That is just a method of treating the ovarian pathology of endometriosis. It does not treat the bowel pathology, peritoneal pathology, bladder pathology. It treats nothing. Like you can't take alcohol and inject it inside a bowel nodule. All that will not work. Understanding?
Okay. And so recurrent cyst, like, so previously she has undergone a cyst aspiration and she has come back with a recurrence. In this cases also, would you choose to do sclerotherapy or would you directly
If
counsel
it is
for?
cyst aspiration, then
Yeah.
there is no problem because another walling off would have happened, madam.
Hmm.
Understanding?
Hmm.
If it is cystectomy already done,
Hmm.
then sclerotherapy is not recommended, madam.
Okay. And what about the quality of the oocytes that you have got in your cases that you have?
Very good. In fact, I'll tell you, if you do adhesiolysis, the cortical blood supply is maintained to the ovary. That itself increases or that itself reduces the hypoxia to that developing oocyte inside and increases the egg quality. No matter what you say.
Mm-hmm. And like, do you combine even this bowel resections also in case if it is there while
Yeah,
you?
yeah, everything.
Okay. So why, I mean, alcohol, there are so many other sclerosing agents like betadine or, I mean, other things which you can use.
Ablation is best with alcohol because you want it to go and cause damage to that epithelium of endometriosis which has developed inside that cyst. You want it to go and damage it. Betadine you can use to clean it, madam. Betadine will sort of give it an antimicrobial covering. Understanding? But betadine will go and do nothing to that endometriotic gland.
Yeah.
This endometriotic gland will be a selective small deposit. It's in a 5 centimeter ovarian cyst. This deposit of endometrial tissue could be 5 millimeter.
Yeah.
Understanding? You want something to go and kill out of that 5 millimeter. You want it to go and kill, let's say, 4.5 millimeter. That 0.5 millimeter you don't know, which is why I am giving OCPs for 50 days.
Mm-hmm. So the complications mentioned in the literature are like infection, pain, and abscess formation. So pain, yeah,
Abscess formation is the
most
worst thing I had seen, which is why I was not willing to do it. Then this Vismay forced me that no, you think and you devise something, and we have to do it because there is a role, and then we figured out.
And or like, do you flush it with saline? I think you said that you flush it and then
Yes.
inject the
First,
alcohol.
aspirate the endometriotic cyst completely. If there is a clot, put Hylace with saline, re-aspirate, remove. Then you can clean with normal saline once. It is very simple, madam. Your needle will not even move. Everybody will be so happy that they have contributed to that surgery, and then you put that alcohol inside it. And when you put alcohol inside it, then just block it. It's full
So
time pass after
do
that for 15
you check
minutes.
the volume that you have aspirated? Depending on that, you decide on the volume that you will push.
No. In fact, even see, once the cavity is collapsed, alcohol should be only that much enough to distend that cavity by a little.
Yes.
What if you distend by it, let's say make a full balloon, that alcohol in the center will feel so bad. It is not able to go and act onto that endometriotic tissue. No, it will feel so bad. So just distend it enough for it to go and act onto all the endometriotic glands. That much is more than enough, madam. Now, sometimes it can be 10 cc, sometimes it can be 30 cc. It is dependent.
So no, it was given that anywhere between 70 to 90% of the volume that you have taken out from that cyst should be put using the alcohol. So I don't think you believe in that. So how many minutes do you leave it in contact for that?
15.
15?
I'm keeping it for 15. I don't know what is the effective time limit.
Okay. So, I mean, how do you rule out malignancy in these cases before you actually post them for sclerotherapy? I mean, is there a way?
No, only by putting the laparoscope. That's why I said put the laparoscope first. You will come to know where that ovary is hiding somewhere. You will have some idea, okay, of capsule being broken, all these things. You will know, right?
Yeah. Yeah, I think we are good. I think this is all I had to. So you think definitely sclerotherapy is an option for especially for consultants who are not into extensive laparoscopic surgeries? Do you want to give that message, or having a
No,
good laparoscopic
it is
knowledge?
an extensive laparoscopic surgery
Hmm.
to do a good sclerotherapy.
Yeah. And
That
also,
is the message.
yeah. And
So
also,
all people who are only doing sclerotherapy can continue to do it, no problem, but it will have no benefit.
So there shouldn't be a puncture, like, I mean, to hold that alcohol inside for those 15 minutes. So there shouldn't be multiple punctures when you actually poke the needle inside
No.
that capsule. So what?
Single puncture.
Yeah.
Go through the thickest part.
Yes.
Even if you have to go through posterior cervix, okay. Even if you go through little transmyometrium, okay. No problem. Go through the thickest part.
Yeah. And so it is very important throughout the procedure not to take out that needle when you are aspirating. I mean, keep that needle.
Never.
It is just one prick and just keep
One
the
prick.
needle there.
Yeah. Sometimes needle will get blocked. Beautiful it is. Many times it happens. What sometimes? It happens every third case. Okay.
Yes.
In that situation, you should flush it. But remember, when you flush it, no, that flushing somebody who is very strong and they use all their effort to flush it, no, that will break the cyst on the opposite side. Understanding that has also happened to us. So that can happen, madam.
Yeah. Okay, I think we are good. I think this was excellent. Thank you very much for sharing your practical experience of so many cases of doing sclerotherapy in spite of being an excellent endometriotic disease surgeon. So thank you. I hope people have got the right message that this is not as a replacement for the surgery. This is complementary to the surgery where it deals with only the ovarian part of the endometriosis. Yeah.
Yeah, and how to know the thickest part? You will do the ultrasound and you will know. It's so easy to know on the ultrasound. It's no problem.
Yeah. Have you abandoned any procedure in between, saying that like this is structured or it was very thin walled, which we see in some cases?
Yeah, madam. It will happen in every 1 in 20. It will happen.
Okay. Yeah. So thank you very much. I think it was a good session. Thank you everybody for joining us. Thank you.